Ирина, вы здесь? Я поняла, она все равно не мешает.
Ragazzi, vedete il video?
Ирина, включите. Ирина.
Ma sembra un po' Tonino Carino con questa duffientezza. Tonino Carino d'Ascoli.
А что за Ирина к нам подключилась? Не переводчик?
Нет, я не знаю.
Но она в видео включает. Катя, у нас Ирина, никто не отвечает вообще ничего. Подключилась какая-то Ирина, которая на фоне ковра, она вообще не переводчик. Я не понимаю, кто. Сейчас назначим. Now everything's fine. The interpreter here. We will announce you when we are online.
One, two, three, four, five, English language, sound check, sound check. Please confirm you can hear me. Please confirm you can hear me. This is interpreter speaking. This is interpreter speaking. Please thumb up on the screen, and I understand that you can hear me. Please thumb up. Thank you, thank you, thank you, gentlemen. We are set and ready. I'm your pale shadow for today. Please don't speed up, otherwise my second name will be changed to Mrs. Kalashnikov.
Francesco, could you share your presentation?
Can I start?
We'll announce when we
okay.
start.
Okay.
And Plinio is moderator. I think that he will introduce this.
Okay.
I correctly understand.
Okay, can I start?
Yes, please start.
Okay. Good morning to everybody. It's a privilege for me to be part of this important international meeting, the Eurasian Congress of Internal Medicine. My name is Plinio Cirillo from University of Naples of Italy, Federico II, and I am very happy to share this important symposium by the title New Insights in Cardiovascular Medicine with my colleagues and friends, Professor Francesco Loffredo from University of Trieste, Giovanni Cimino from University of Campania, Luigi Vanvitelli, and with another friend of my institution, Dr. Luigi Di Serafino from my university. But let's move to the first presentation from Francesco Loffredo, by Francesco Loffredo. The title of presentation is Molecular Therapies and Models for Cardiovascular Disease. Please, Francesco, share your presentation with us.
Thank you, Professor Cirillo. Thank you for the nice introduction, and welcome to everybody. It's my pleasure to be here today. I'm actually the group leader of the Molecular Cardiology Lab at the International Center for Genetic Engineering and Biotechnology here in Trieste. And today, the topic of my talk will be addressing the new discoveries in cardiovascular research that have added new tools, especially molecular therapies. And I will share with you a novel model that we have developed in my lab, and I think it can contribute to understanding better the biology of cardiomyocytes. I will start by stating the obvious. Of course, you all know what is the burden of cardiovascular disease worldwide. Indeed, they represent almost 30% of the global deaths that are every year in the world, and more than what cancer can kill. And if we think that aging is one of the most important risk factors for cardiovascular disease, as you can see from this graph, the fact that the world population is aging can represent an important thing to address in the next few years. Indeed, if you consider this panel, you can see how, what is the projection in the changes of the population age in the next 30 years. You can see that the population of people that are aged 65 or 60 or more will be more than 30% in the developed countries. And if you think the impact, the socioeconomic impact of this problem in the world, you must admit that the need of novel therapies is really, really needed. The event, the most tremendous event that can happen among cardiovascular conditions is the loss of contractile tissue after acute myocardial infarction. As you can see here, if nothing is done, there is repair by scarring, and eventually this can lead to dilatation and heart failure. Of course, we can partially address this problem by performing percutaneous coronary intervention by restoring blood flow, but we have to account also for that can protect and recover spare some contractile tissue. The problem is also the damage due to the reperfusion that indeed can worsen the outcome. Thus, the action of cardioprotective drug that can be administered immediately or after PCI can also help to spare contractile tissue. But nothing can be done on the residual scar tissue if not the use of regenerative drugs that can push resident cardiomyocytes to divide and to replenish the fibrotic tissue. As I was saying before, the major problem is that ischemic heart disease can end up in developing heart failure. That is a prevalent deadly and expensive disease. If you look at the stats from the US, you see that there are almost 5 million of people in the US with congestive heart failure, with almost 400,000 new cases every year. And the thing is that 50%, there is a 50% at 5-year mortality for heart failure. It's a very deadly disease. And if you think about that, the cost associated with treating heart failure, including hospital admission, is almost $40 billion. What has been done so far, it's actually, especially in the last decade, is the development of new drugs. Those new drugs are really good in stabilizing the disease. However, they can do little on restore the function that was before the ischemic event. And this is why the need for novel therapies comes to hand. And you know, it has been suggested different approaches that can actually try to prevent the development of heart disease by addressing myocardial ischemia, or can actually reverse the heart failure phenotype by restoring contractility or by restoring muscular tissue that has been lost. Different approaches have been proposed. For example, cell therapies using exogenous cells. The problem would be what kind of source. A lot to try. Some of these cells have been used in clinical trials that have failed for a number of reasons, including fraud, honestly. Another possibility is to use synthetic recombinant biotherapeutics like protein, small interfering RNAs, microRNAs. They can actually change the genetic program at cardiomyocytes level. And also gene therapy, but the problem would be what kind of genes are really important to address this problem, what kind of vector can be used, and everything to stimulate neoangiogenesis to produce myocardial protection and eventually to induce myocardial regeneration. You can see here that gene therapy clinical trial have been in the cardiovascular field are among 9% of total, with cancer leading all of them. And considering the pathophysiology of heart failure, and considering that the main phenotypic aspect is the loss of contractile function, gene therapy has been addressed to improve those pathways that specifically control calcium handling within the cardiomyocytes. And indeed, the possibility of upregulating adenine cyclase 6 or SERCA2A or I1C, and specifically the vectors that have been used in this case have been adenovirus or adeno-associated virus. Adeno-associated virus is a very, very good tool to deliver the gene therapy. It's actually, we here in Trieste, we also have a facility producing those vectors. But there are also drawbacks with the use of AV vectors, because indeed you can develop an immune reaction to AV vectors. That means that you have one shot, because the second shot, if you don't have already antibodies, if you develop antibody, it won't be useful anymore. This is a panel just summarizing some of the clinical trials for heart failure using gene therapy. And what has been done, as I said, has been proposed to use SDF1. This is a chemokine that is a chemoattractant that can home progenitor endothelial cells. And thus, the idea was that this could improve angiogenesis in the infarcted heart. Or, as I said, increasing the expression of SERCA2A, that is downregulated in heart failure. And although some preclinical studies were very, very exciting and very promising, some phase 1 trial were very promising, as shown here, the Cupid trial using this MIDICAR. MIDICAR was an AAV1, one is the serotype, carrying the SERCA2A. And it started with 39 patients with ejection fraction below 30%. And it was divided in 3 groups with 3 different doses. And what was seen at 12 months was that it was safe and there was a significant clinical improvement. And that actually triggered the phase 2 trial, and that's where it actually failed. And enrolling almost 300 patients, it has been shown that it was neutral. There was no benefit from the injection, and that you have to consider what could be the reason of that. What I think is that the idea of addressing heart failure just by improving contractility is not addressing the major problem, that is almost invariable cardiomyocyte loss in heart failure, and the fact that there is absence of cardiomyocyte regeneration. Here you can see the control, and you can see how the scar replaced the lost cardiomyocytes. And even by, you can push the residual cardiomyocyte to contract more, but nothing can be done to replace the lost cardiomyocytes. And this happens because the adult mammals, including humans, they fail to regenerate lost cardiomyocyte, but after cardiac injury. And the lost healthy myocardium is replaced by fibroblasts, by a scar. But this is not true during the embryonic phase or immediately in the postnatal period, where there is still the capacity of cardiomyocyte to re-enter cell cycle and to restore the lost myocardium. This does not happen, for example, in the adult mouse. So what's happening? Why there is the regenerative capability of cardiomyocytes is lost immediately after birth in a window that in mouse is about 7 days. There is, of course, there are some putative factors that have been proposed to explain this. And for example, the increase of reacting oxygen species, changes in microRNAs, activation of Hippo pathway, and the downregulation of neuregulin pathway that can induce cardiomyocyte regeneration, and also the sudden increase in workload that happens immediately after birth. As I said before, the possibility of replenishing lost cardiomyocyte using exogenous cell has been addressed. But so far, I have to say that using different kind, like adult stem cells, pluripotent stem cells, that has been pretty much a failure, a total failure, because of many. I mean, this is not the time to address specifically this matter, and thus non-cellular strategies have been proposed. For example, trying to stimulate the endogenous capability of cardiomyocyte to regenerate that is lost in the adulthood. For this reason, in my lab, we took advantage of this model that is the engineered heart tissues. Engineered heart tissues have been developed as a drug screening tool, and they are basically an unpurified, in this case, an unpurified population of neonatal rat cardiomyocytes in a fibrin matrix, and they are casted using silicone posts that can allow to sustain the tissue that develop over time. And the advantage of this is that you can perform also functional studies by measuring the contractility and the force of contraction of EHTs. And you can also do histological studies. You can do molecular studies by doing RNA sequencing, by doing Western blotting. You can do whatever you want, like having a tissue. The other important thing is that you can produce EHTs by using cardiomyocytes that have been developed using induced pluripotent stem cells. So using, for example, cells of a patient with a specific genetic cardiovascular disease. The advantage of EHTs when compared to 2D cultures is that you can perform long-term studies. There is a very low proliferation activity at basal. And also you have a high degree of cardiac differentiation and maturation, thus resembling what you have in adult cardiomyocytes. And as I said, contractile function can be measured, and this process is easily made with accuracy. We have observed, we have investigated what happened in maturation of EHTs by measuring the incorporation of BRDU into the nucleus of cardiomyocytes, indicating DNA synthesis, the presence of binucleated cardiomyocyte, that is a marker of maturation of cardiomyocytes, and the force of contraction that is developed. As you can see, over time, what we observe is a progressive decrease of DNA synthesis here in red, together with an increase of binucleated cells. And together, you can observe an increase of force of contraction that reaches a plateau. If you compare this with what happens with the neonatal cardiomyocytes after birth, you observe in vivo a progressive reduction of DNA synthesis together with an increase of binucleation. And this is important because this system can resemble what is happening in vivo. So the idea was that by changing, as I said before, one of the factors that can be responsible for the loss of the regenerative capacity of cardiomyocyte is the sudden increase in the workload. Thus, our hypothesis was that by reducing the loading condition on EHTs could increase the DNA synthesis in cardiomyocytes. Indeed, by performing an unloading, a reversible unloading experiment, we have observed a significant increase in the number of cardiomyocytes incorporating EDUs. That means that they were synthesizing DNA. At the same time, we observed a decrease in the expression of genes that are associated with cardiomyocyte maturation, thus indicating that those cardiomyocytes were going back in their maturation stage. On the other hand, we also tried to test the hypothesis that by increasing the afterload, this could actually reduce the number of dividing cardiomyocytes. Indeed, although it was not significant, we observed a decrease in the number of EDU positive cardiomyocytes, together with a more organized sarcomeric structure. We then used another approach that we have developed here in the lab to perform change irreversibly the loading condition, both increasing or unloading. And this is just a schematic. As you can see here, the unloading in mature EHTs produced a significant increase in EDU positive cardiomyocytes, together with an increase in Ki67, histone 3 positive cardiomyocytes, indicating that DNA synthesis was accompanied by cell division. This proliferation was present only at the beginning when the change of the unloading condition was produced, like at day 2, as shown here. And then the effect is lost over time because there's probably a new homeostasis that actually thus indicating that the trigger to that produces these changes is the change in the loading condition. We also observed that when we increased after load, this produced an improved sarcomeric structure with a significant increase in this cross-sectional area of cardiomyocytes, together with an increase in the number of increase in the force of contraction, as shown here. And also when it's normalized by number of cardiomyocytes. The other thing also that we observed that was that this sustained increase in the afterload produced a consistent increase in the number of binucleated cardiomyocytes. As I said before, binucleation is a marker of maturation of cardiomyocyte. Thus indicates that our model can actually recapitulate what is happening in vivo. Our next step is to understand what are the mechanisms that can actually control these events. If you think, for example, that in patients that with failing hearts, where a ventricular assisting device has been placed, the authors observed an increase in the number of phosphohistone 3 and the Ki67 positive cardiomyocyte, indicating that the unloading conditions that are produced by the VAD was actually contributing to induce cardiomyocyte proliferation. Thus, you can imagine that in a not very in a long future, the idea could be to use something to unload the heart and give the time to cardiomyocyte to proliferate and restore the lost cardiomyocytes. So the take-home message is that our EHTs, they definitely represent a novel and valuable model to study postnatal cardiac biology, and indicates that mechanical loading is definitely a master regulator of cardiomyocyte, both proliferation and maturation. And as I said, we are performing experiments to understand what are the mechanisms that can regulate this process. And the lesson learned from the gene therapy study is that, and for future gene therapy study, that is really important to address the efficiency of gene delivery. What kind of animal models have been used in the preclinical study, how the study has been designed, and of course, one of the most important things is the choice of the therapeutic gene. Thank you very much for your attention.
Okay, thank you very much for your impressive presentation with a window to the future to Professor Loffredo. And then let's move to the next presentation. I changed my rule in this symposium, and the chairman became a speaker. The next presentation is about the emerging role of non-conventional risk factors in cardiovascular disease. Okay, great. Oh, as you know, the cardiovascular risk factors might be divided in two great categories. The first one represented by risk factors that cannot be modified, such as age, gender, genetic factors, or race, and other risk factors that might be modified, such as hypertension, smoking, diabetes, physical inactivity, or hypercholesterolemia. And you know that many efforts have been done in the last 30 years from the European Society against specifically hypertension and dyslipidemia. However, cardiovascular events still happen. So we can speculate that there are other risk factors that we don't know yet. In fact, the conventional risk factor might be considered as the peak of an iceberg, and the part of the iceberg that is under the sea might be represented by not conventional risk factors. And today, this morning, I want to share with you some thoughts about this argument. The first non-conventional risk factor that I want to consider is the uric acid. An important study published several years ago on atherosclerosis, thrombosis, and vascular biology, the Monica Cora study, demonstrated that the levels of this compound are associated with all-cause and cardiovascular disease mortality in general populations. And as you can see, the increased levels of uric acid in the plasma are associated with a significant increase of cardiovascular mortality. And in particular, it was considered that several levels of this compound, till 6 milligrams for deciliters, can consider good. Over, we are in the field of warning or danger for cardiovascular disease. Another important study performed in patients with acute coronary syndromes evidenced that the close relationship between the mortality and the plasma levels of uric acid, suggesting that this compound might be considered as a marker of extension of disease and of outcome in patients with acute coronary syndromes. And our group has recently evaluated the impact of uric acid in a small number of patients with ACS. And we have observed that those patients with high blood levels of this compound have increased level of an indicator of myocardial damage, suggesting that those patients in which the levels of this compound in the blood were higher had a worse outcome considering the extension of cardiovascular damage. Again, we observed that those patients with elevated levels of uric acid had complex coronary lesions, suggesting that the extension of atherosclerosis in the coronary circulation was higher in those patients in whom the levels of uric acid were elevated. And if we consider the complex network in which this compound is involved, we can see that several mechanisms, first of all, endothelial dysfunction, platelet activation of the renin-angiotensin system, might be considered responsible of several clinical effects such as hypertension, atherosclerosis, heart failure, or atrial fibrillation. And of particular interest was the observation that in those patients with ACS, coagulation-mediated event, the estimation of mortality was higher in those patients with ACS and with elevated blood levels of uric acid. In this context, we have investigated whether this acid might be considered as an effector of ACS. And in fact, we have demonstrated that in the human endothelial cells stimulated with uric acid, increasing concentration of uric acid were associated with increase of TF procoagulant activity. That, as you know, is the key player in the activation of the extrinsic coagulation pathway that, together with platelet activation, play a pivotal role in the pathophysiology of ACS. So, another non-conventional risk factors might be considered OSAS, sleep apnea. This study published a few years ago on Journal of the American College of Cardiology clearly demonstrated that patients with sleep apnea had an increased rate of myocardial infarction during the night as compared to patients without this disease of the sleep, suggesting that there was a closer association between the sleep apnea and myocardial infarction. And the pathophysiological mechanism involved in this phenomena are reported in this slide, in which we can see that sympathetic activation, the endothelial dysfunction, one more, the pro-inflammatory state, might lead to several events, such as the activation of the renin-angiotensin system, the enhancement of coagulation, the activation of substances with an activity as a vasoconstriction, can lead to systemic hypertension, ischemic disease, heart failure. Again, obesity. You know that obesity is associated with several clinical disease important as cardiovascular risk factor, conventional risk cardiovascular risk factor, such as diabetes or hypertension. But I want to change my point of view about obesity, considering that the dysfunctional adipose tissue that we can find in patients with obesity is characterized by a close relationship with the cells of inflammation, monocytes and macrophages specifically. So we know that in patients with obesity, we can see a pro-inflammatory constant situation characterized by production and secretion of pro-inflammatory adipokines that finally can lead to cardiovascular disease. Specifically, we know that in obese individuals with dysfunctional fat, we have an increase of several inflammatory mediators such as interleukin-6 or some specific adipocytokines produced by adipose tissue such as resistin and leptin that have been demonstrated to be associated with the development of cardiovascular disease and myocardial infarction. And in this context, several years ago, we have performed several experiments demonstrating that leptin might induce a pro-atherothrombotic phenotype in human coronary endothelial cells by inducing expression of tissue factor and of CAMs. And the same goes from the resistin that induces the tissue factor activity in human endothelial cells in vitro by the NF-κB-dependent pathway. Finally, we have to consider another important non-conventional risk factors and represented by gut microbiota. As you know, the microbiota is represented by all those microorganisms physiological located in the gut, where these microorganisms are directly involved in several important physiological functions. However, we know that in the gut, the microbiota can go to an alteration of its normal function and can produce several compounds that can cause atherosclerosis or other important disease. And in this context, an important role is due to trimethylamine and to its oxide form, trimethylamine and oxide. This study published in the European Heart Journal a few years ago demonstrated the close relationship between TMAO plasma levels and all-cause mortality risk. And in the context of atherosclerosis and cardiovascular disease, several studies have demonstrated that increased levels of TMAO can induce and promote atherosclerosis, finally leading to myocardial infarction and stroke, can induce enhanced platelet hyperactivity that, as you know, are responsible of acute coronary syndromes. And at the end of this chain, we can find heart failure. And this paper published just yesterday in Cardiovascular Research proposed a different approach, not with drug, but with a different kind of diet to induce a normalization of microbiota diversity to reduce inflammation and activation of immunity, to finally reduce the impact of the microbiota on cardiovascular disease, reducing hypertension, atherosclerosis, heart failure, and probably, I'm not sure about this, atrial fibrillation. But I think that we have to consider other non-conventional risk factors, the so-called emerging risk factors that must be considered in the last years. Indeed, the European Society of Cardiology a few years ago, about 10 years ago, considered these emerging risk factors and started to consider the detrimental effects that environment can have on the heart. Greta will be very happy for this consideration. And in fact, we know that several aspects of environment, such as air temperature, air pollution, noise, seems to be closely related to the development of cardiovascular disease, with an increase of cardiovascular mortality with acute myocardial infarction, heart failure, and stroke. This meta-analysis, published a few years ago, demonstrated that studies dealing with cold and heat were performed and have indicated the close relationship between temperature and cardiovascular disease, both for mortality outcome and for morbidity outcome. And in this context, I believe that this study published 2-3 years ago from the CORA study group demonstrated that a temporal variation in temperature was associated with a significant increase of myocardial infarction, especially in patients with diabetes or hyperlipidemia. Probably diabetes was associated with endothelial dysfunction that caused the impossibility to lose calories with increase of air temperature. On the other side, this interesting study demonstrated that the increase in temperature was associated with the decrease of HDL, the so-called good cholesterol levels after 4 weeks, and with the increase of the so-called bad cholesterol represented by low-density lipoprotein. So this study indicated that the increase of temperature was associated with a change in the lipid profile of these patients, these individuals. Finally, we have to consider that in patients with heat stroke, there is an activation of immunity and of inflammation, and at the same time of coagulation. All those pathways that have been indicated to be responsible of pathophysiology of acute coronary syndromes. But we must consider that in the modern times, specifically in the metropolis and in a great city, temperature is closely associated with air pollution. And in fact, this study that for me is very important demonstrated that the effects of temperature are very strong when temperature is associated with air pollution. And as you can see, when temperature, heat, and cold is associated with air pollution, we have a shift towards an increased mortality in the population. This study published from Thomas Mansell demonstrated that about 50% of excess death due to ambient air pollution per year in Europe are due to cardiovascular disease. 40% ischemic heart disease and 8% stroke, cardiovascular disease at all. And in this context, a great importance in air pollution and cardiovascular disease seems to have the PM2.5, because several studies have demonstrated that short-term elevation in PM2.5 increase the risk of acute coronary events by 1 to 3% within a few days. But longer-term exposures for years increase the risk till 10%. due probably to the development of cardiometabolic conditions such as hypertension and diabetes. And in this context, another important add factors is represented by acute ozone exposure. In this slide, I want to show you how the relative risk increase in mortality increase when PM2.5 increased concentration in the air are associated with an air with high ozone, suggesting that the presence at the same time of PM2.5 and ozone is responsible of an increase, a huge increase of mortality, especially in our cities, in several parts of the world, such as in India or in China, as you know. However, in this slide, I want to show you that the air pollution has been well characterized as responsible of adverse cardiovascular effect as all-cause mortality and cardiovascular mortality. Poor evidence about, or better, emerging evidence remains unquantified about hypertension, diabetes, non-fatal myocardial infarction. But I believe that the next years we will have literature to support this zone 2. And finally, poor evidence are actually in the literature about the close relationship between thrombotic disease, ventricular or atrial arrhythmias, air pollution. However, if we can see the mechanism, this slide summarizes the mechanisms by which air pollution might induce cardiometabolic disease. First of all, the oxidative stress with the activation or endothelial dysfunction, the activation of immunity of thrombotic pathways leads to the activation of immunoinflammation with a low-grade inflammation that, together with the oxidative stress, induce a cardiometabolic disease. Let's move on the next emerging risk factor. Robert Koch said a lot of years ago that one day man will have to fight the noise as other disease. And I want to show you that this is true. In this study published a few years ago, the authors have evaluated in about 5,000 persons the impact of noise on hypertension. Because they evaluated the impact of noise of patients that lived near any 6 major European airports. And you can see that the highest were the levels of noise, the highest was the risk of hypertension. And this meta-analysis demonstrated that noise was associated with noise due to road traffic was associated with the development of coronary heart disease. And in the study published in the European Heart Journal, underlined that this event was more pronounced in patients in the elderly. In this study, the authors evaluated the impact of road traffic noise on stroke. And as you can see, the impact was strong, especially in patients with about 70 years old. In this several mechanisms have been suggested to be involved in this phenomenon. In particular, chronic stress due to noise can induce an increase of catecholamines in the blood with activation of all those mechanisms responsible of increased level of cortisol. Finally, we have an enhancement of thrombosis, of endothelial dysfunction, the activation of angiotensin and of renin, and finally the activation of the inflammatory pathways. In this context, endothelial dysfunction seems to play a pivotal role. In this study, patients were evaluated after several days of exposition to noise, and then was evaluated the endothelial response to acetylcholine and norepinephrine. And as you can see from this slide, endothelial dysfunction was evident because they lose relaxation and they enhance the vasoconstriction. So the endothelial of these patients after 4 days of noise was significantly perturbed. Again, in this study from the same German group by Thomas Munzel, evaluated the impact of train traffic on sleep and how this noise affected the endothelial, the endothelial function by evaluating the flow-mediated dilation. As you can see, when the noise was very high, the flow-mediated dilation was very low, suggesting that endothelial dysfunction was significantly impairment. And this slide summarizes all the mechanism by which air pollution, noise might induce cardiometabolic risk. By obesity, chronic inflammation, hypertension, diabetes, and atherosclerosis. But which kind of solution we can find to fight against these emerging risk factors? Sure, we have to consider the importance of governmental intervention and social intervention. At the same time, we have to consider some aspects of our life, avoiding pollutants from the government, increasing the use of personal face masks, staying indoors when the pollution is very, very high. And in this context, an emerging rule has been considered for the dietary supplements. This slide summarizes all those studies that have considered diet supplementation with vitamins such as vitamin C, vitamin E, or some food to increase the levels of antioxidants in the blood. And several studies have demonstrated a benefit by adding this vitamin to the daily diet. On the other side, the drug intervention have demonstrated that statins might be considered as drugs of choice to reduce the impact of pollution and of the emerging risk factors on cardiovascular disease. And this is my last slide to indicate what happens in that study that I showed you a few slides ago. By adding vitamin C to the normal diet in those patients in which flow-mediated dilation and endothelial dysfunction was present, reduced the impact of the noise due to train traffic, and increased the restored the flow-mediated dilation and the endothelial dysfunction. I want to thank you for your attention. And now I became again, I changed my role again from speaker to the moderator. I want to invite the next speaker, Giovanni Cimino, to speak about the cold kitchen and cardiovascular disease, the second half of an old drug. Please, Giovanni.
Thank you, Professor Cirillo. It is a pleasure for me to be here today. I would like to thank you, the scientific committee, for the invitation, especially for giving you this talk on the new role of colchicine in cardiovascular disease. As we know, atherosclerosis is the major contributor of cardiovascular disease. It is a lipoprotein-driven disease characterized by deposition of lipoproteins and other blood-borne materials within the arterial wall of almost vascular district. The diseases progress silently with the focal clinical manifestations that are mainly due to the plaque rupture with superimposed thrombus formation. Since 1999, the role of inflammation in the atherosclerosis pathogenesis has been proposed. In the last 20 years, accumulated evidence have reinforced the role of inflammatory and immunocompetent cells, such as monocytes and T cells, in contributing to the development and complication of atherosclerosis. Thus, researchers start to move to check which marker was the best to indicate a possible role in patients with cardiovascular disease. And C-reactive protein has been proposed as an excellent epidemiological marker, as reported by several groups. Here I report one of the first paper from the group of Paul Ridker, showing how high levels of C-reactive protein are able to indicate a worse prognosis in patients for cardiovascular diseases. And the marker becomes even stronger if it is associated to high level of low-density lipoprotein. Data from our group and others show that patients presenting with acute coronary syndromes show an increased level of C-reactive protein in coronary circulation. And these levels are associated with an impairment of endothelial function. On the other hand, in an in vitro model, always from our group, we reported how smooth muscle cells and endothelial cells exposed to increasing dose of C-reactive protein express tissue factor that is the main initiator of a coagulation cascade and promote cell proliferation. Other data also indicate that in vulnerable plaque, we can find high level of collagenase expression, especially matrix metalloproteinases. Data from our group and others indicated how smooth muscle cells exposed to C-reactive protein may express high level of matrix metalloproteinases 9 with high level of matrix metalloproteinases activity in endose-dependent manner. In vivo findings show that patients presenting with ACS may have high level of matrix metalloproteinases 9 in coronary circulation, and these levels correlated with the transcoronary levels of C-reactive protein. Moving on inflammation, other reports indicated that not only CRP, but several other cytokines may be involved in the acute presentation of coronary artery disease. In this report, we found how different cytokines, mainly related to the Th1 response, are associated with the acute event. And in a subset of patients, we find that patients with high level of interleukin-17 may have high level of troponin, thus indicating an increase in the myocardial damage. Starting from this data, several groups, one of these is the Peter Libby's group, starting to study the role of inflammation modulation in atherosclerotic diseases, such as interleukin-1, mainly interleukin-1 and interleukin-6. And they proposed a model in which inflammation relating to these two cytokines may induce thrombus formation and plaque instability. Several clinical trials have been recently published on this field. Some others are still ongoing. The first trials on the use of low-dose methotrexate failed to show any improvement in cardiovascular events in patients taking these drugs. Other study involving the use of tocilizumab that is an interleukin-6 blocking antibody, indicate how patients may improve. The use of tocilizumab is associated to an improved myocardial salvage and a reduction in high-sensitive C-reactive protein and troponin release. Another study, that is the CANTOS study, with the use of canakinumab, that is an interleukin-1 beta blocking antibody, show how the use of this medication lower the plasma level of C-reactive protein, interleukin-1 and interleukin-6. And this reduction is associated to a reduction in cardiovascular events, cancer, and gout attack. Recently, other papers have been published on new role of colchicine in cardiovascular disease. Around 2 years ago, the COLCOS trial have been published showing the use of low-dose colchicine in patients after acute myocardial infarction. And more recently, the LODOCOS-2 trial have been published a year ago, presented to the European Society of Cardiology in 2010, reporting how low dose of colchicine, even in the setting of stable patients, is associated to a reduction of cardiovascular events. 2 more studies are ongoing and are expected to be complete in the next few years, still exploring the dose of colchicine in the setting of cardiovascular disease. Thus, starting from this clinical data, a new life for colchicine is expected. I would like to remind you that colchicine is an anti-inflammatory drug originally extracted from the Colchicum autumnale. And it has a broad cellular effect that includes inhibition of tubulin polymerization and alteration of leukocyte responsiveness. It is approved in clinical practice for use in the treatment of familial fever and gout. And from the Cardiology Society here, the latest guidelines from the European Society of Cardiology 2015, colchicine is approved as a first-line choice in the treatment of acute and recurrent pericarditis. However, to date, the benefits for for the management of cardiovascular disease is still not known completely. The primary mechanism of action of colchicine is represented by tubulin disruption, a phenomenon that can cause downregulation of multiple inflammatory pathways and the modulation of innate immunity. Previous data indicates a possible role in the cardiovascular disease in the acute and chronic setting. In December 2019, on New England Journal of Medicine was published the COLCOT trial, the result from COLCOT trial. More than 4,000 of patients with an acute MI in the latest 30 days, and the use of low-dose colchicine showed a reduction up to 23% in primary composite endpoint, 74% in post-MI cardiovascular arrest, and 50% of reduction in post-MI urgent angina, hospitalization, and revascularization. As said before, a year ago, the LODOCO-2 trials was published, presented to the European Society of Cardiology. More than 5,000 of patients enrolled in taking colchicine, low-dose colchicine, 0.5 milligrams per day versus placebo, showing a significant reduction in the primary endpoint of cardiovascular death, myocardial infarction, ischemic stroke, or ischemia-driven coronary revascularization. Also, a significant reduction in the other secondary endpoints, including cardiovascular death, myocardial infarction, or ischemic stroke. Thus, these two big trials are indicating that we can get on top of therapy more benefit for cardiovascular patients by using colchicine. The mechanism response of these cardiovascular benefits is still not known to date, and our group have focused the last years in addressing this issue on platelet aggregation, on endothelial function, and on T-cell modulation. In this first paper, published in 2018, we explore the effect of colchicine on an in vitro model of platelet aggregation, reporting how pretreatment of platelets with colchicine is able to reduce platelet aggregation. And this effect is mainly related to the inhibition of the key players in cytoskeletal modulation. Another paper that comes a year later on in vivo use of colchicine, we report an additional effect on antiplatelet aggregation of colchicine, even in patients on dual antiplatelet therapy with clopidogrel. And this effect is higher in patients that are clopidogrel not responders. Another paper that has been published on the beginning of this year, we also show that pretreatment with the colchicine is able to reduce expression of tissue factors at gene and protein levels, as well as translocation on cell surface, reduction in the activity, procoagulant activity, and this effect is related to a blocking of intracellular trafficking from the nucleus to the cell surface. Ultimately, we have this last paper that got acceptance just last night, in which we have explored the effect of colchicine even in T-cells. A previous report from our group has shown how activated T lymphocytes may express tissue factor in vitro and in vivo. In this paper, we reported that pre-incubation of cells in a vitro model of T cells with colchicine is able to prevent and reduce tissue factor expression at the gene and protein level, as well as procoagulant activity, and to reduce surface translocation. This effect happens even on top of rosuvastatin treatment. Thus, based on this accumulated evidence from our group and others, we can conclude that colchicine exerts significant cardiovascular benefits in patients with acute and/or chronic coronary disease. This effect seems to be mediated by a direct effect on platelet aggregation via cytoskeletal modulation, preventing atherothrombotic phenotype of endothelial cells and modulating T cells activity. Thus, a new use for colchicine begins. Thank you very much for your attention.
Okay, thank you to Professor Cimino for this interesting presentation. And now let's move to the last but not least, Professor Luigi Di Serafino, an outstanding scientist in the field of coronary microcirculation. The title of the talk is Not Angiographically Significantly Coronary Stenosis, to treat or not to treat, which is the role of a fractional flow reserve to guide coronary vascularization. Please, Professor Di Serafino.
Thank you, Professor Cirillo. I would like to thank the organization for this kind invitation and Professor Cirillo for this kind support. So this presentation will highlight the role of fractional flow reserve for deciding on the opportunity to treat or not to treat an intermediate coronary artery stenosis. To treat or not to treat, someone told us. Actually, first of all, we should admit the limitations of the coronary angiography. First of all, we are talking about a 2D angio. So this means that the operators need to acquire different projections in order to have the best resolution of the coronary artery stenosis we are facing with. In addition, sometimes it's difficult to assess the reference diameter of the vessel we are evaluating, especially in case of diffuse disease. And this, of course, is because the angiography highlights the lumen of the coronary vessel. So in case of diffuse disease, the degree of the coronary artery stenosis will be underestimated. In addition, we should recognize that our eyes normally can play with us. In fact, we can see that this circle here on the left seems bigger than the other one here on the right. But actually, this is not the case. They are equal. What is different is the rest. So the main limitation of the angiography is mainly represented by the fact that the coronary angiography only detects 5% of the total coronary tree, being the rest represented by the microcirculation. But is it important to assess the ischemic potential of an intermediate coronary artery stenosis? Well, if we consider this lesion, this subtotal occlusion of the circ, the mid part of the circ, probably this is not the case. This is a critical lesion, should be treated. But what about this lesion in the mid part of the LAD? Is it responsible of myocardial ischemia? And is it important to assess the ischemic potential of this lesion? Well, actually, we know that that a patient is significantly more likely to die or have a myocardial infarction if he has a lesion causing myocardial ischemia. In addition, the benefit of revascularization is extremely higher than the medical therapy alone, especially in patients with a large ischemic burden, higher than 10%, as we know from the Akamovich paper. So we go back to the coronary tree, and we have to divide the coronary tree in two main compartments. So we have the conductive arteries, which that are highlighted by the coronary angiogram, the coronary angiography, and the microcirculation. Now, the microcirculation is particularly sensitive to metabolites, and it vasodilates after the injection of hyperemic drugs such as the adenosine. And this is particularly important because this is on the basis of the autoregulation mechanism, which is the ability of the heart of maintaining flow constant in case of any change of perfusion pressure without intervention of any other external mechanism. So this means that in case of a reduction in coronary perfusion pressure, the flow does not reduce, but will be constant. And the same will occur also in case of any increase in coronary perfusion pressure. And we can represent the coronary tree in this way, in this schematic way. So here we have the epicardial compartment with its own resistance. And then we have the microcirculation compartment with its own resistance. So the flow is actually this ratio, so the difference between the two pressures, so at the top and at the bottom of this system, and the two resistance, so the epicardial resistance and the myocardial resistance. So in case of the presence of an intermediate coronary artery stenosis in the epicardial compartment, we, of course, produce an increase in terms of epicardial resistance, but the flow has to be constant. So for the autoregulatory mechanism. So the microcirculation reacts by reducing its own resistance. So the flow is constant. And the same will occur even for other stenosis, a larger stenosis, but it will be the case that at the end, the coronary microcirculation cannot reduce its resistance any further. So in this case, the flow will reduce, and our patients will experience some chest pain. So we can introduce the EFFR. So the FFR is basically the ratio between two flows. So the flow in the stenotic vessel and the flow measured in the same vessel, but in the hypothetical case of the absence of any stenosis. So we can simplify only during maximal hyperemia and bear in mind the mechanism of the autoregulation, this ratio in a ratio between the two pressures. So the pressure measured below the stenosis we are going to measure, and the pressure measured above the stenosis we are assessing. So for a value, an FFR value lower than 0.80, we are facing with a functionally significant coronary artery stenosis. Differently, for an FFR value higher than 0.80, we are facing with a non-significant coronary artery stenosis. This is a nice case example of a patient presenting to our cath lab with an ST elevation myocardial infarction and this thrombotic lesion in the proximal part of the LAD. But after the successful treatment of the proximal LAD, we found also these intermediate, almost critical stenosis in the proximal part of this posterior lateral branch of the circ, and nothing, almost nothing on the right. So what to do with this lesion? Is it important to detect ischemia? Yes, we have shown the reason why it is important previously. And this is the reason why we took the patient back to the cath lab a few days later and we measured the FFR. The FFR was negative, so we left this lesion alone, only with medical therapy. What we need to, in order to measure the FFR in our cath lab, we need the analyzer, we need of course, the hyperemic drugs such as the adenosine, which can be injected by bolus, intracoronary bolus injection, or through an infusion pump. We need, of course, the patient, and we need also an intermediate stenosis somewhere in the coronary tree. But most of all, we need the interventional cardiologist who is going to ask himself whether or not this intermediate stenosis is really responsible of the symptoms experienced by our patient. So at this point, we need a wire, or we need a microcatheter, or whatsoever. We need something which can measure the pressure distal to the coronary artery stenosis. At this point, we are ready. We have the guiding catheter positioned at the ostium, in this case, of the left coronary artery, or the left main. And then we use this wire with this sensor located here 3 centimeters before the tip. At this point, we need to two systems speak the same language. So the two pressure, or the one coming from the guiding catheter, the red one, and the one coming from the wire, the green one, should be equal. So this operation is called equalization of a different mechanism, normalization. So at this point, we can advance the wire beyond the stenosis. In this case, the stenosis located the proximal part of the ostium, this margin branch. And then we can inject our hyperemic drug, such as in most of the cases we use adenosine. At this point, we can wait for the lowest PDPA value. So in this case, we got a value of 0.64, so the lesion was functionally significant. But do we have enough evidence in order to leave non-functionally significant coronary artery stenosis alone without PCI, without revascularization? We have a huge amount of data coming from the last 10, 20 years. And the different study was the first study who showed that deferring the treatment of non-functionally significant coronary artery stenosis was safe. In addition, in the FAME trial, we found that an FFR-guided revascularization strategy in patients presenting with multivessel disease is safer than the revascularization based on the angiography, on only the angiography. In addition, treating functionally significant coronary artery stenosis in the FAME2 trial has been found safer than leave this kind of lesion alone with medical treatment, with optimal medical treatment alone. What about in the acute coronary syndromes? We have also a lot of data coming from this kind of population. So in the pre-multi trial, in the RAMI3 pre-multi trial, it was found that complete revascularization guided by the FFR measurement of the non-culprit stenosis is safe and reduce the primary endpoint as compared with patients undergoing PCI of the culprit lesion only. And the same was also found in the COMPARE-ACUTE trial, where in this case, in patients with STEMI and multivessel disease, when they went primary PCI, the adoption of FFR-guided complete revascularization of non-culprit coronary arteries in the acute setting resulted in a lower risk of a composite cardiovascular outcome as compared to those patients who were treated for the infarct-related artery only. We know that in the European guidelines strongly recommend in the setting of chronic coronary artery syndrome, the use of FR in order to assess the ischemic potential of intermediate stenosis, intermediate coronary artery stenosis, in the case the patient comes to our cath lab without any non-invasive test, and particularly in the case of multivessel disease. So we should be, so we have a lot of data supporting the use of FFR for the treatment of intermediate coronary artery stenosis. And we should be prepared to rely upon our brains rather than on our eyes, because what we measure is basically more reliable than what we usually see. Thank you.
Okay, great. Thank you, Professor Di Serafino, for this very interesting presentation. We have a few minutes for some questions from the audit, and we have a lot of questions about colchicine for Professor Cimino. One of these might be, have any new limitation appeared for the use of colchicine in view of the new therapeutic indications?
Thank you, Professor Cirillo. Thank you, the audience, for this question. It is a really interesting question. Well, to date, based on the data that we have from the in vivo and in vitro study, I believe that we can expand the use of colchicine in cardiovascular diseases. In the COLCOT trial, the percentage of patients that discontinued the medication was very low. The major adverse event reported was the gastrointestinal discomfort, but it happened in a very low number of patients. Thus, we can select colchicine as a really new drug in these diseases, taking into account that cortisone and methotrexate failed to manage inflammation in cardiovascular disease. Thus, as the presentation indicates, a new use for this medication begins.
Okay, great. We have time for another question for Professor Loffredo. a very interesting question considering the new window and the future of cardiovascular disease. The question is, how pressing is to carry out genetic testing in patients with cardiovascular disease, and if so, in which population? Again, is the testing highly informative, and are there any new promising markers?
Thank you very much for the question. Well, genetic testing can still be problematic. The reason is that many times, because of it's very easy now to sequence the whole genome. Sometimes it's very difficult to distinguish something that can be really pathogenic. And most of the times, this requires a lot of preclinical work and a lot of preclinical study to determine whether or not a single polymorphism or a new mutation can be associated to some disease. But for instance, I would like to carry the case of inflammatory cardiomyopathies. There is an ongoing evaluation of patients with myocarditis, and especially with recurrent myocarditis, where the mutation of desmosomal genes can be actually responsible for this kind of disease. In this case, genetic testing, genetic sequencing can actually increase the possibility of detecting this kind of disease, extending this to the whole family. But I think we still have to be very careful in using gene sequencing for everything.
Okay, thank you. And last question after the interesting presentation of Professor Di Serafino. Are there any special aspects of conservative treatment of patients with non-angiographically significant coronary stenosis that we have to consider? Activate your microphone.
Yes.
Okay.
Yes. Thank you for this interesting question. So, in case of presence of non-functional significant coronary artery stenosis, of course, the optimal medical therapy is the choice, the main choice, and it also depends if we found a non-functional significant coronary artery stenosis in the context of diffuse disease or in the context of multivessel disease, and in this case, it can be that the patient has also the indication for PCI in the other vessel. But it is important also to understand whether or not the patient, on top of the presence of a non-functional significant coronary artery stenosis, has a dysfunction of the coronary microcirculation, which can be also the reason of the symptoms. In fact, it is possible that even in case of a PCI of a non-significant coronary artery stenosis, in most of the cases, the patient still has pain. In fact, we know that almost 20% of the patients coming to our cath lab and who undergoes to PCI still experience some chest pain at the end of a successful procedure. But this depends on the microcirculation. So it's extremely important to assess the pathophysiology and the physiology of the entire coronary tree in order to select the main therapy for this patient. The aspirin, in this case, is extremely important because, of course, patient has always a coronary artery disease, even though the stenosis we are facing with does not induce ischemia. And then we need something which preserves the coronary microcirculation. It has been shown how RCA inhibitors, RB blockers, and can play an important role. And then we need something that, in case, of course, in case of vasospasm, we need something that is able to act on the entire vessel.
Okay, thank you, Professor Di Serafino. I have just 1 minute to close this important symposium. I want to thanks again the organization of this very important and interesting international meeting. And I want to thanks all the speakers for the high levels, scientific level of their presentation. And I want to finally thank the audit for your attention and for the interesting question. I hope to see you in the next years at the same place and probably in presence. Thank you again and have a nice day and a great meeting. Thank you again.
Good afternoon, dear colleagues. I'm very happy to welcome you the results of new prospective clinical trials. And today we will just get immersed into the world of new prospective studies results. We are going to have a look at the new data available about COVID-19. That was the most important topic at this symposium last year. Once again, we will just travel between different cities all across Russia, and also we are going to travel to CIS countries. We will start from the first presentation. It will be made by Svetlana Perepelitsa from Kaliningrad, a Doctor of Science, Professor of Surgical Department of Kant University, and Lead Research Fellow of Rheumatology Institute of the Institute of Rheumatology of Moscow. So the topic, glycemic profile of patients with new infection COVID-19. Svetlana, you have the floor. Thank you very much. I would like to thank the organizers for the invitation to this wonderful forum. And today we are going to speak about some aspects related to glycemic profile of patients with COVID-19. And well, COVID is the topic which is widely studied, its development, its progression, and over the past years of the pandemic, there are lots of results which appeared, clinical and scientific, and they are changing very quickly, and new data, scientific data is added, and of course we get the new knowledge that we need to use and discuss. We know that RNA of the virus is found not only in lungs and blood, but in all of the internal organs, in liver, spleen, endocrine system. And also it is very typical to have polyorganic dysfunction. And what prevails, it's difficult to say. That is a big problem for us and for our patients. That's why we decided that we should discuss that. Also, there are deviations in carbon exchange, and our goal is to determine these processes in COVID patients. We included 114 patients who were admitted to hospital with COVID diagnosis. They had acute onset, high fever, shortness of breath, and intoxication. And also we were treating and looking for the reasons. Firstly, they were treated in outpatient clinics, then in hospital. And when they were admitted, all of them had the diagnosis of coronavirus, and depending on glycemia level, so we split them into two groups. Hyperglycemic group, so patients who during treatment or when they were admitted for the first time had a blood sugar elevated. That were 77 patients, age 62, a body weight 83, and that was day 7. And the normal sugar group, their glycemia was stable, and there were no changes in this indicator. These were 64 mean age, body weight 42, and 167 centimeters of height. They are also 7. And as we may see here, we do not see significant difference between these two groups. That's why we believe that this sampling was quite representative. We identified 3 points of the first, 3rd, 5th, and 7th day. During treatment, all of the patients had test for leukocytes, CRP, ferritin, laxatigreanase, and LDG, and also glycemic profile. We see that both groups of patients had ferritin level during treatment was elevated, was quite high, and did not change. And LDH, lactodehydrogenase, and there was no trend towards its decrease, and there was no significant difference between the group. CRP was also increased, and in hyperglycemic group it was going down a little bit faster, but there was no statistically significant difference. Leukocyte was at the same, and glycemic level is something which drew our attention. In hyperglycemic group, the patient was admitted that had elevated sugar, so carbohydrate metabolism was impaired when the disease is progressing. When they are treated in outpatient clinic, they not have the glycemic controls, and during all of the treatment, the average numbers for glycemia was elevated compared to the patients of the group with the normal blood sugar. One of the factors which potentially impacts the carbohydrate metabolism is hypoxia and breathing insufficiency, acute one, in normal group in 51%, in hyperglycemic group in 70% of patients. This is statistically significant difference. And of course, the endocrine gland is the target organ for the virus. There is deviation in microcirculation, which impairs blood supply, so the pancreatic gland is suffering the may cause organic dysfunction. And also it causes this balance of insulin production. So in the acute period of a new coronavirus infection, because of coronavirus infection, 68% of patients for the first time had the carbohydrate metabolism disorders, which is pronounced by hyperglycemia, and they have elevated blood sugar. For the discharge moment, there is no normalization of carbohydrate status, so they are in high risk group for diabetes. Glycemic level should be controlled during treatment and also after discharge from the hospital, and there can be a new type of diabetes associated with COVID-19. Because of that, we need multi-central control trials, and based on that, we would like to suggest questions for discussion, which are very important. Yes, of course, we need to control glycemic sugar levels for all patients with coronavirus who are being treated in outpatient clinic. In hospitals, we need to do ultrasound of pancreas to assess its involvement into pathological process. When hyperglycemia was diagnosed for the first time, we need to provide diagnostics in order to make the diagnosis ASAP and understand that these changes are reversible and they are temporary, and after discharge from hospital, it is necessary to continue monitoring and diagnostics to exclude diabetes, and also we need to develop the program of early rehab for such patients after COVID-19. Thank you for your attention. Thank you, Svetlana, for your presentation. Dear colleagues who are listening to us, I would like to remind you that you will have an opportunity to ask our participants questions after we finish with the presentation. We have 20 minutes for that in the end. And you may write them in the chat. So, Svetlana, should we assess the C-peptide count for these patients? You recommend to do abdominal ultrasound, and in particular for pancreatic gland ultrasound and C-peptide. Is it an important marker? Well, I think that's an important approach for early diagnostic of potential complications which these patients may have, because now we are just talking about lung diseases and also severe pneumonia, but we are just missing the problems that we are not actively discussing. Yes, of course, this is a topic for discussion and our new studies. Thank you, Svetlana. for just dedicating time to such important aspects as glycemic profile of our patients. And as we have been fighting against this awful infection for over 18 months, so we are not assessing this profile, trying to save the lives of the patients, and we just forget about these things which are important for us and for the future of this patient. So now we have the presentation by our colleague Елена Королева from Nizhny Novgorod, a clinical medical faculty from Lobachevsky University, cardiologist of Clinical State Hospital number 5 of Nizhny Novgorod. Ekaterina will speak about the peculiarities of a cytokine profile in patients of COVID-19. Well, hello, dear colleagues. Unfortunately, the pandemic of COVID-19, which took the lives of over 4 million people, continued to exist, but as we have new scientific data, we understand more deeply the pathogenesis of the infection. So, Ekaterina. So, dear colleagues, we are having some technical issues, and it happens from time to time. So we are live, so there may be some issues. Zoom also has some technical complications. And I had the same problem and yesterday. I suggest that the next speaker will start, and then we will come back to Ekaterina, and we will continue talking to you. There is no sound. We shift to the next presentation. We'll come back to Ekaterina after this one. Aygul Zinatulna from Kazan, the wonderful city of Kazan, chronic obstructive pulmonary disease with frequent severe exacerbations, the role of comorbid pathologies. Aygul is the Assistant Research Fellow of the Faculty of Internal Medicine of the State University of in Kazan. So I will speak about frequent severe exacerbations of COPD and the role of comorbid pathologies. Well, frequent severe exacerbations are one of the main causes of disease progress, as well as the main cause of death in patients with COPD. Of course, comorbidity is an important risk factor, and for its progression and independent risk factor for death, and significantly affects the prognosis of chronic obstructive pulmonary disease patients. Up to 50% of cause of death are extrapulmonary. As we may see, among the risk factor for chronic obstructive pulmonary disease and among the risk factors for its exacerbation, there are different comorbidities, and that's why we should study also the comorbidities in COPD. So the aim of our study was to identify the features of comorbid pathology in patients with frequent severe exacerbations of chronic obstructive pulmonary disease. We analyzed medical records of patients hospitalized in Terapevtov part of hospital in Kazan with exacerbation of COPD for the last 4 years, and during this period of time, 423 patients with exacerbation of COPD were hospitalized, and the 147 patients were hospitalized 2 or 3 times a year, and this is the main group. In the control group, 276 with a one-time hospitalization per year. So there were 55 men who prevailed, and also the average duration COPD was found in this group, and they have the longer average smoking experience. And we found out that almost 1/3 of the main group, despite exacerbation, continued smoking at the time of admission. Only about 10% received the recommendation to stop smoking when they were discharged from hospital. It was also found out that 40+ years of smoking experience increased the risk of repeat hospitalization by 1.6 times. And also in the main group, the number of patients with severe patients was 2 times more than in the control group, which could also make the condition more severe, triggering frequent exacerbation. With the increase in the number of comorbidities, it was found that the control group patients had at least minimum of 1 or had no comorbidities, and in the main group they have 3, 5 or more comorbidities, and in the main group, so they had only 1 comorbidity or no comorbidity, and the control group had +2 comorbidities. So, and the risk is increased by almost 3 times in case of comorbidity. So the patient from main group from frequent exacerbation had arterial hypertension, IHD, so in second A, GERD, pneumonia, and bronchiectasis. So the difference is statistically significant according to our data. So of the patients in the main group had almost 2 times less patients with body deficit. Is different from the literature, as well as the number of patients with excessive weight was equal for both main and control groups, though in the literature there are cases of body weight mass deficit in patients with a severe COPD and exacerbations, and it requires further study. So it was discovered that arterial hypertension increases the risk of repeat hospitalization by 3.5 times, and the presence of chronic heart failure by 1.5 times, the presence of GERD by 3 times, and also history of significant bronchiectasis may increase the risk of frequent exacerbation by more than 2.5, and development of pneumonia may increase the risk by 1.5 times. And we concluded that the presence of over 3 comorbidities, and the presence of 3 or more comorbidities increase the risk of repeat hospitalization with exacerbation of COPD by 2 times. The most important comorbidity is CHF, hypertension, and GERD. That's why active therapy of the comorbidity comorbid pathologies may decrease the risk of repeat hospitalization of patients with COPD and decrease the impact on the main disease. And the duration of smoking exceeding 40 years and also presence of continuous smoking with the chronic obstructive pulmonary disease also increase the risk of repeated hospitalizations for COPD, and it makes it more meaningful. So we need to fight against smoking, and we need to recommend the patients to stop smoking. Thank you for your attention. Thank you very much, Aygul, for a wonderful presentation. I fully support you about stopping smoking, and that's very good for your health. Dear colleagues, we are all here to answer your question in the end of the presentations. Now we come back to Ekaterina, the doctor from Nizhny Novgorod. And she will speak about the cytokine profile in patients with COVID-19. Good afternoon, dear colleagues. The pandemic of COVID-19 took the life of over 4 million people, and it continues to exist. And having new scientific data, we understand better the mechanisms of the infection, and it will help us to develop specific treatment, which will decrease the number of acute and severe patients, decrease mortality, and also, I would like to remind you the infection mechanism. So, with the help of SARS-2, so ACE2 ferment and TMRSS2 type, they are activating, and the viral membrane are getting together with the membrane of the cell. They use other cell receptors as free RDPin1 and CD147 active replication. Its release causes pyroptosis of the cell, so the cells are dying, and different molecules and interleukin-1 beta, which is the pyroptosis marker, and different acids, so they are recognized by epithelial cells and macrophages. And also IL-6 MCP1, this is protein 1 interferon gamma induced protein 10, and MIP alpha and beta. Then the T cells are attracted as well as monocytes, and with help of interferon gamma, the positive loop reverse inflammation back loop is created. To the right, most people with the help of immune response limit the inflammatory process, and the infection doesn't cause damage of cells. And specific T cells which get to the inflammation point inactivate infected cells, and neutralizing antibodies inactivate the virus itself. Alveolar macrophages recognize and phagocytise apoptotic cells, though patients with comorbidities such as diabetes, hypertension, and coronary heart disease, they have a dysfunctional immune response. There is a big release of pro-inflammatory cytokines, accumulation of immune cells, and non-neutralizing antibodies may enhance the infection because of antibody-dependent enhancement of infections. There is the cytokine storm, which appears and which progresses to other organs and systems, causes polyorganic insufficiency, which is the predictor of unfavorable prognosis of the disease. So our goal was to identify dependency between the cytokine profile indicators and clinical progression in patients who were admitted with coronavirus, and we need to assess their prognostic importance. The total number of patients was 70, mean age 58, 40 men, 30 women, hypertension 50, comorbidities, ischemic heart disease 25, diabetes 19, COPD 2, asthma 2, and the venous blood was taken on admission day, and the average days of the blood analysis was day 7. So we did the clinical blood assay, the comorbidities, body temperature, saturation, CT, grade, CRP, DD-MIR, a total blood count. With the help of multiplex, we receive 47 cytokines and chemokines interleukin from 1 to 18 colony stimulating factor of granulocytes, MCP1, interferon gamma induced protein 10, TNF alpha, and different inflammatory chemokines. And we use the Spearman criteria with visual control of diagrams and exclusion of release, and from 0.4, from 0.0.2 the correlations were weak, from 0.4 that was mean, and 0.6 and more severe. Interleukin 6 was significantly elevated for patients with severe COVID, correlating with CRP, fibrinogen, DDMIR, while the patients with moderate and mild disease, so the increase of the cytokine was not found. This also we may see the high elevation of TNF, tumor necrosis factor, with severe CT, and there were high numbers and high correlation between the severity in CT and data in MIG, MCP1, interleukin 8, 15, 18, and also the correlation was medium, so the DDMIR level, CRP, fibrinogen correlated with severity of the patients as well, and the levels of cytokines such as MCP1, and the duration of hospital stay, which was calculated for beds and days, correlated with interleukin 15 and MCP1. Here, the correlation was quite weak, not significant. Also, we have the reverse correlation between saturation and different cytokines, MIG, MCP, IL-8, 15, and IL-18, which is quite logical. According to our data, we may prove a hyperproinflammatory response in patients who needed oxygen support. Based on this data, we can assess early predictors of progression of COVID-induced inflammatory response. We may forecast the severity of progression in this patient when he is just admitted, and also we may decide upon third immunosuppressive treatment before severe lung lesions. So we only have the first results, so the studies are ongoing. We hope that our results will have clinical importance. Thank you for your attention. Thank you very much, Ekaterina, for your presentation. So it worked. And this is an important presentation. And I just would like to praise everybody who works with coronavirus infection, because just we have all friends and colleagues who suffered from COVID. Thank you so much for your presentation. We have next presentation, Mr. Gavrilenko, our colleague from Minsk, PhD in medical science. Will speak about acute to chronic liver insufficiency, the new model in clinical practice. Dmitry, you have the floor. Thank you, Grigory. I would like to just welcome you, dear colleagues. I would like to just present our small work. The day before yesterday, I partially spoke about this new syndrome. What kind of syndrome is that? Acute to chronic insufficiency. We have acute and subacute, and we have the chronic hepatic insufficiency. Well, and European scientists, based on multicentral study, which included over 1,200 patients, they offered a new concept, and in most publications, they call it the new concept, which means not only acute decompensation of cirrhosis, but also non-liver organs are damaged, and it causes short-term high rates of mortality. Patients with liver cirrhosis, they have hepatic insufficiency because of the terminal stage of the diffuse liver disease, but some of them they have some acute decompensation, not only of their liver insufficiency, but of non-liver organs. And acute hepatic insufficiency as debut of cirrhosis and decompensation in patients with the liver cirrhosis diagnosis usually is reversible condition, and the patients will have chronic terminal decompensation. In most of the cases, they don't have regression, and they just end up with mortality. And as for this syndrome, it's important that this syndrome just appeared, but as of today, we have about 20 definitions of this syndrome. And the important situation, we have several associations which study the liver, and they concluded that ESL concluded that this is the acute worsening of early diagnosed chronic liver disease related to some provoking factor. And also, according to the Asian Pacific Association, so they offer their own definition of acute on chronic liver insufficiency. So it may develop in patients with the liver disease and also undiagnosed chronic process, which is progressing. And what is peculiar about APSL, so patients with the kidney and lung insufficiency, which are one of the criteria according to the European Association, these patients are, for this association, for the Asian Pacific, this is the exclusion criteria, and they also are going to, there is a definition by the Chinese group and the American Association. Of course, there is some discordance here, but these scales are multi-stage, and they considerably increase the current scales which are used to assess the decompensation of hepatic insufficiency. So this is the regression of liver function, which gets to terminal decompensation, and this is the liver function on patients with the liver disease, so alcohol abscess, so medication lesions, and COVID-19 and other infections which provoke this balance. And also, the organ does not work, but this is reversible. And here we have the week, only 1 week, when we may just stop the pro-inflammatory status and the cytokine storm which is being formed, and just stop the progression and stop the onset of polyorganic insufficiency. And when we assess the 20-day mortality, according to this study, it was deduced that around 4%, it's absence of insufficiency when there is a failure of two or more organs, so the mortality increases up to 70%. Well, the pathogenesis should be defined using the concept of period. So this is the abbreviation from English, which includes predisposition, injury, response, and failure. And also expression of TLR receptors in liver D cells. They activate pro-inflammation in norm, in the liver compartment, the expression should be lower. That should be the case because liver always constantly contacts with the GIT microbiome, but patients with cirrhosis may have higher expression of these receptors in B cells. So as for predisposition and genetic factors, and factors of life, these factors are different in Europe and in Asia. If in Europe and the USA the main risk factor for liver disease is alcohol, then in Asia these are viruses, and in India acute hepatic insufficiency associated with hepatitis E. So the injury itself, or the triggers, or the factors, these may be bacterial infection, bleedings, activation of a viral infection, alcohol, and some more rare causes. As for the infection, you know that the main mechanism for patients is bacterial translocation, and also there are other causes of infection which cause transitory bacteremia, and with immune suppression in such patients, because they have cirrhosis, they can prolong bacteremia and just shape bacterial locus, and patients with cirrhosis are very susceptible to viral complications. And according to a canonic study, one of the factors for an acute compensations, well, there were no factors actually found. Probably the next studies will clarify that. Well, just summarizing this section, I would like to say that healthy individuals are tolerant to inflammatory response, and cirrhotic liver inadequately accepts lipopolysaccharides and TNF-alpha. So we may speak not only about hyperproduction of pro-inflammatory cytokines, but decrease of liver or hepatic tolerance. And it was proved in several studies studying the extracorporeal support, which does not lead to improvement of the condition. Now there is a treatment which has been developed to reduce cytokine response, and as you may understand, this is target therapy. We are talking about Bayer medications, and there are several ongoing trials and studies to assess efficacy of these drugs for the group of patients with acute on chronic hepatic insufficiency. And the main conclusion, or acute on chronic liver failure, and the main response of hepatologists is the following. So the multi-level scale is much better compared to the scale MELT, and it is used for patient selection for liver transplantation. And here there is a question whether we may use the new scale today. Yes, today we know that it's not used for selection of patients for liver transplantations, but also there are lots of questions about liver transplantation around this, because that's the most efficient way to treat it. And as for the scientific part, Natalia Silivonchik was leading this work. We tried to use this criteria, the criteria for the news in our reality, because we were talking about European patients. Can we use these criteria in our country? And we analyzed the data of 154 patients retrospectively. They were treated in GIT department of just a regular city municipal clinical hospital, and mean age was 55 years, 56 male, so the compensated C class, and 16 days average hospital stay. So this is the Cliff C scale. So this is the severity and the scale that we used of acute on chronic liver failure. And according to our data, 29% of patients with liver cirrhosis had this syndrome. And in the hospital, it progressed. You may see the components of this syndrome. And Also, kidney insufficiency, kidney failure was 1/3 because kidney injury is the negative prognostic factor, and coagulation insufficiency, respiratory insufficiency failure was in less patients. The first grade of acute on chronic liver failure, so 1 or 2 organs, and we try to analyze the triggers or factors into groups: patients with this syndrome and without syndrome, and the bacterial infection and GIT bleeding in these in patients with the in the group of ACLF were associated with this syndrome. When we try to split into different types of infectious and different types of complications, there was no statistically significant difference among the two groups. And we tried to make a cluster analysis, another optional statistical analysis. So stage 2 and 3 of acute and chronic liver failure were in the same cluster together with the bacteriemia and spontaneous bacterial peritonitis. So what's the difference from acute and chronic? From acute decompensation of, and this is decompensation also of acute type of other organs, which is combined with the short-term mortality, and the number of type of failures identify the risk of mortality. In 30% of patients, we found this syndrome. Among the criteria, liver and kidney failures were prevailing. Severe bacterial infections, bleeding from upper GIT were associated with more severe grade of acute and chronic liver failure. Dear colleagues, that is it from my side. Thank you for your attention. And Grigori, yes, thank you very much for your unique presentation. Our conference is very valuable, and you may just listen to different specialty doctors at the same symposium. And what is even more unique, you may ask the question to each of them, and maybe you may ask just some question which was of interest for a long time. You have a great chance to do that. And when we finish our symposium, you have Q&A. And from Minsk, we travel to another wonderful city, to the city of Kyiv. Larissa Bodretskaya, general practitioner, cardiologist, PhD in medical science. She will speak about COVID-associated structural functional changes in the heart in elderly patients. Larissa, you have the floor. Dear colleagues, thank you for giving me the opportunity. This is a great honor for me to speak at the Eurasian Congress of therapeutic doctors, so there is no conflict of interest. Over the past 2 months, we have been discussing a lot the excessive mortality during the pandemic times, and in the slide, we may see the data of 2020, and of course, this mortality cannot be explained without progression of chronic pathologies, including cardiovascular diseases. COVID-19 is a long-term, multisystemic, under studies, immune-dependent disease. Starting from the 2nd week, immune-dependent stage is starting, manifested in inflammation of microvessels. In the slide, you may see all the sample of microvessels infiltration with leukocytes. So this is alveolar, and we see the fibers, fibrinic fibers. To the right, these are microvessels of lung. This is endothelium, which was injured by the infection by COVID-19 because of endothelial cells death. And of course, looking at this image, you may just understand that, or you cannot get rehabilitation the same period of time as quickly as after you had a cold. So the heart injury related to microskeletal thrombosis, direct impact of the virus, toxic effect of cytokines, and development of autoimmune process. In autopsies, we find infarctions, cardiomyopathies, and myocarditis. And in this slide, we may see the study published in European Cardiological magazine, an ESC, sorry. And so this is 148 patients with severe COVID infection with troponin positive myocardial injury in post-COVID period. In 26% of patients, myocarditis-like changes were found. In 22% of changes, percent of patients, they had infarctions, ischemic changes, and dual pathology in 6% of the cases. Well, 1/3 of ischemic patients, they found it for the first time during this diagnostic, and that's not clear whether that was de novo infection, de novo after the infection, or it used to be latent and no myocardial fibrosis was found. In our department, the patients are followed up for a long time, and also they have some elective diagnostic sessions, and the patients who are on long-term follow-up, we had 56 patients with diagnosed and proved COVID. 31% of them had symptoms which persisted after the infection, so it was 55%, which is in line with the global data on the prevalence of post-COVID syndrome. In order to analyze correlations of its progression and prevalence and frequency of post-COVID syndrome in elderly patients, we created a questionnaire. The patients fill it in when they're admitted to our department. Thanks to that questionnaire, we identify some specific syndromes and symptoms. So this is changes in the angina, and that was a typical pain. And so it should be, so this Unger pectoris, so had the pain which lasted over 30 minutes, and then the cardiac insufficiency class was shifted, and also there was also shortness of breath found, and also what we found, the correlation of between prevalence of post-COVID syndrome from 4 main factors. So the severity of acute period, moderate and severe patients were more prone to post-COVID syndrome. Duration of treatment in acute period, patients who were treated for a longer time, they had less chances for post-COVID. Anticoagulant treatment, even short-term period of anticoagulants in acute period of COVID decreased the probability of post-COVID syndrome, and timely correction of basic cardiological therapy decreased the probability to develop post-COVID syndrome in an elderly person. And in echocardiography, our patient had increase of the right ventricle, right atrial, and the contractility of the right atrium, and also lung artery pressure was increased, and diastolic, and there were also changes in diastolic volume and contractility of the left ventricle. That was more than in non-symptomatic patients. In elderly patients in post-COVID develop the ventricular cardiac insufficiency case, the patient 84, acute COVID in March 21. Moderate oxygen-dependent post-COVID symptoms persisted for 6 weeks. And for 6 weeks after onset of the disease, she had high inflammation rate. 3 months after the disease, it was the same CRP, was 5.5 times elevated in echocardiography. We found compared to previous years, left and right ventricle were enhanced, contractivity was enhanced, as well as the pressure in the lung artery. And there are positive changes after treatment. The patient, we decreased the dosage. Amlodipine was canceled, so we used telmisartan 80 milligrams, and we increased the doses of rosuvastatin, and we added we needed to decrease the symptoms of post-COVID syndrome and alter the hypertension. And in current guidelines for rehabilitations, there should be personalized approach to each patient. And the guidelines say that after COVID-19, after the infection, we may suspect cardiac diseases in each patient. We thought about the targets of post-COVID syndrome. And the first thing we need to do to optimize the basic therapy to restart it. And we need to base the treatment on personal needs, and we may use also the drugs against inflammation, which is non-stopping statins. Entoxaphylline is an interesting medication. I will speak about that later. The patient needs endothelin dysfunction correction. We need to suppress excessive stress and also the antagonist of mineralocorticoid receptors, and because this is something which is important for angiotensin levels, which are elevated. Immunological effect of pentoxaphylline are quite interesting. It can decrease migration and proliferation of leukocytes, decrease the cytotoxic direct effect on the cells, decrease indirect cytotoxic effect because the production of cytokines decreases. It decreases production of hemokines, expression of adhesion molecules on endothelium cells, and decreases apoptosis. I would like to mention one study where pentoxaphylline started from acute coronary syndrome episode, and in 6 months of therapy, there is a consistent decrease of inflammation and inflammatory cytokines, and the increase in the cytokines which fight against inflammation. And I also would like to mention that the progression of heart insufficiency and damage to the target organ. So here we have aldosterone. So this group of medication may be used. The more the science is advancing in studying the causes of diseases, so the more relevant is the phrase that it's better to prevent the diseases than treat them. So that was said by Ilya Mechnikov. Thank you for your attention. So of course we may not disagree with Mechnikov. Thank you for your work and your presentation. Now we travel to the host of our event. Mrs. Severina, Now just we are hosting that in St. Petersburg. So the chief specialist of cardiology rheumatology department of the Institute of St. Petersburg, peculiarities of clinical records of patients with infarction and diabetic nephropathy with polymorphic types of genes NOS3 ApoE and SLCO1B. Dear colleagues, well, the topic of my presentation will speak about infarction, diabetic nephropathy, and will touch upon about a new area, which is personalized medicine, and will just speak about the genes. And also, we should not speak about the relevance and importance of cardiovascular diseases. So they remain among the leaders in terms of mortality, disability, and among the causes of absenteeism at work. And the main role here is for infarction, which account for 6.5% in mortality among the mortality from diseases of blood circulation. So cardiological patients, they usually have a big records of comorbidities, and these comorbidities are also widely studied, and a lot of attention is paid to them because, as a rule, the patients which have comorbidities, diabetes, chronic kidney disease, obstructive pulmonary disease, and obesity, and so on, and the prognosis for infarction is worsening because of comorbidities, and they have lots of complications. The impact of diabetes on progression of infarction, well, that's an important topic because it's an important risk factor. We may just speak about the pandemic of diabetes mellitus. You may see how many people suffer from it in Russia. We also have this problem. In this slide, you may see that we have over 10 million of people in Russia with diabetes. I think this is a low number because many patients even do not know they have this disease. So, personalized medicine. Well, that's quite a new term, and the dear colleagues heard about that. And then it's called individualized medicine. Sometimes this is a new area of medicine which uses a diagnostic approach to identify specific biomarkers. Usually these are genetic biomarkers which help to understand what kind of treatment and diagnostic will work better for each specific patient. One of the areas is personalized medicine. So these are the predisposition gene studies, and given certain factors, these genes contribute to development of a certain disease. I should also mention that pharmacogenetics development and cardiogenetics change the approaches to diagnostics and treatment of many diseases. I think that many colleagues had patients who are not sensitive to clopidogrel, for example, or have low sensitivity. And let us just move to the stories we would like to present. So the goal was to assess the peculiarities of hospital progression in patients with diabetic nephropathy, which are carriers of polymorphic variants of genes NOS3, ApoE, SLCO1B1. And there were 210 patients who were admitted to our emergency hospital with myocardial infarction. Male prevailed, mean age 65. They were split into two groups. The first group was 107 patients with infarction, and these patients also had diabetes and diabetic nephropathy. And the second group, 113 patients, infarction patients without diabetes and diabetic nephropathy. So the clinical laboratory tests, analysis, diagnostics were the same, and gene detection was the using the polymerase reaction, the PCR, and we separated the DNA from leukocytes with this method, and also we use the contrast to identify the injury of kidneys. Before we move to the result, I would like to explain about the gene. So gene NOS3. So this is the gene coding the enzyme synthase of oxide of nitrogen, which is localized in chromosome number 7. And according to different studies, it was demonstrated that patients who are carriers of a homozygote or heterozygotic genetic variant of this gene are more prone to develop ischemic heart disease, acute coronary syndrome, and other changes in cardiac activity, arrhythmias. And we see that diabetic nephropathy patients had monozygotic carriership of this polymorphism more frequently, and ApoE genes, it is responsible for the synthesis of a protein, apolipoprotein E, and this protein is included into atherogenic lipoproteins of and also its deviations causes the functional impairments, and lipoprotein level is increased in the blood, and they suffer more from ischemic heart disease. And based on the Boyan study, so there is association of lipoprotein E, so they have 5 times more frequent these issues compared to non-carriers of these polymorphisms. In the first group of the patients, heterozygotic type of this polymorphism was more frequently found, and total cholesterol and lipoproteins of low density were assessed, and lipoproteins of low density, well, they were statistically more elevated, as well as cholesterol. So SOCO1B1, so it is also responsible for the synthesis of the transport protein, but it's responsible for statin transfer to liver, and changes in the nucleotide sequence of these genes cause changes in the protein structure. There is accumulation of statins in the blood, and we know that statins may damage muscles, and their hyperlipidemic effect is decreased. And the carriership of this gene, according to studies, speaks about high prevalence of hyperlipoproteinemia. Patients with diabetic nephropathy and infarction also had more heterozygotic sequence of this gene. The total cholesterol LDL demonstrated that the statistically significant difference was only for LDL, which was higher for the first group. Assessment of the clinical condition. The first group patients at hospital stage had statistically more frequently supraventricular and ventricular impairment of the heart arrhythmia, and acute heart failure and chronic heart failure of high grade, which in its place and was translated to hospital mortality. With the nephropathic group, it was more higher. And the main causes of hospital mortality were the following: acute or left ventricular insufficiency, recurrent myocardial infarction, thromboembolism, or rupture of myocardium in one case. While summarizing this study, I would like to conclude: in patients with infarction and diabetic nephropathy, more frequently have heterozygotic type of polymorphism allele 28-PRO of gene ApoE, while 174 L of gene SLOC1B1, which enhanced hyperlipoproteinemia, which was proved by high cholesterol and LDL, and also carriership of homozygotic polymorphism of TT gene NO3 also had an impact on the tonus of the vessel wall, and also in patients who had diabetes, and unfortunately they have more complications, which I presented earlier. So concluding my presentation, I would like to say that today, and there is more and more use of personalized medicine, and of course the genomic tests, they helped this a great deal, and they help to identify the new genetic predictors, assess the risk of the patients, and based on that we may just build our prevention and treatment. Dear colleagues, thank you for your attention. Thank you very much, Anna, for this great presentation. So it seemed to be very recently to be the medicine of the future, and I hope that very soon we all work in line with the personalized medicine. Dear colleagues, now we start the questions, and we have lots of questions which we accumulated. Unfortunately, there are two no ones, so then all of us together will answer those questions, and we will get to the truth in our discussion. So we'll start from the question to colleagues who spoke about COVID, Ekaterina and Svetlana. So the question to we will start from Svetlana. What lab tests you perform for mild progression of COVID in outpatient treatment? As we saw that the glycemic level is elevated at pre-hospital stage when these are patients who are quite elderly, they're 60 plus, then of course we need to control the blood sugar because most of them are in the diabetic risk group, especially when they have comorbidities. And this is our favorite term that we use now. And this is one of the criteria that we need. Of course, transcutaneous methods we use. We also test saturation. We have the opportunities to quickly understand what to do with the patient. And ferritin and CRP level. There is a correlation between the level of ferritin and CRP, so it is correlates with severity of disease progression. So they could be the criteria which will help the doctor understand what to do with the patient, whether he should be admitted to hospital or not, because today he has mild form and tomorrow he may have a progression. And if we don't see what's happening with the patient, we have the late diagnostic issues. And one of the studies, it's not about lab diagnostic, it's about ultrasound of spleen. There is Project Maltese. And we have the first results, and we saw that the patients who are admitted in acute period of COVID, so half of them have microsplenia, so it is shrinking. If we used to talk about splenomegaly, so here we have the opposite changes. It correlates with the injuries of other organs in patients who died. If the patient had microsplenia, so the shrinking of spleen, so this patient may need admission. So I think in Russia we were the first to do that. Now we are preparing the publication about that, but we are talking about early markers which will help us to forecast disease progression. Thank you, Svetlana, for such a detailed answer. It turns out that we may control the sugar level, CRP and ferritin. If possible, do abdominal ultrasound, and not only pancreas in size, but also that of spleen. Well, dedemir probably later, and Ekaterina would like to just add something. Please join our side. Dedemir, I think, is one of the most important markers that we should test at outpatient and stage and hospital stage, because it may speak about thromboembolic complications risks, which is important. Coagulogram should be done. That's a must. And very often the patient have changes in ECG. And at the clinical stage, it is impossible to, because the patient is at home on quarantine, in lockdown, and the ECG is in the clinic. There is a question about the most promising lab markers to make the prognosis of severity of progression. This should be interleukin number 6, which in the future we should test for our patient who just started the disease progression, and we may forecast the severe progression. Thank you, Katerina, for your important comments. I think that all of ours together, we have the set of markers to assess at pre-hospital period if the patient has mild coronavirus. The next question is to Anna. Anna has already joined us. Anna, the question is the following. Prospects of individualized treatment based on genetic profile of patient. Well, that's a great question indeed. It's very relevant. We have experience about lab diagnostics, and there are also private labs on top of state labs, which they compete between each other, of course, and we have different genetic panels. I will just come back to the question, to answer the question. We can also test sensitivity to statins genetically, antiplatelets, anticoagulants, and beta blockers. There are genes which are responsible for sensitivity to these drugs. That should be done at early stage. I mean, the risk of development of CVDs, cardiovascular diseases, hypercholesterol, progression, arterial hypertension, and these panels are quite widely spread. Maybe the person which doesn't have ischemic heart disease, infarction, for example, may do genetic tests and learn about different associations with his genetic code with different diseases, and do early prevention, change his lifestyle, habits, and so on. As for, well, coming back to the question of sensitivity to drugs and based on genetic tests, I think that's going to be developing, and it's in the recommendations of ticagrelor, and patients which has low sensitivity to ticagrelor, we use another medication for him. Clopidogrel, sorry, with clopidogrel, it's ticagrelor. Low sensitivity to clopidogrel, we use TICO for them to prevent thrombotic complications. And the same is true about statins. This gene that I spoke on, SLOC1B1, there are lots of studies which demonstrate different sensitivity to different statins. As a rule, simvastatin is more studies, atorvastatin, rosuvastatin. I did not find these decreased sensitivity in patients. I think it's going to be started. There will be new panels. It will become more accessible, of course. We prescribe these tests on sensitivity probably for patients with complications due to low sensitivity. And I hope that personalized medicine is going to develop actively. It will be more accessible for our citizens. Yes, I also hope Ekaterina, that it will be to the benefit of our patients and in our interest. Practical question: patient 42 years old, obesity grade 2 after COVID, pneumonia CT2, was taking dexamethasone, sugar 8, rheumatoid factors 18, cholesterol 5. If it is a transitory hyperglycemia, what is the tactics to be used? So it does not specify what time passed after COVID. It's like when the person was discharged, cytotoxic action of COVID on pancreatic glands. The prognosis is pancreatic cirrhosis. So I believe the question is to Svetlana. Svetlana, that's the question for you. Svetlana, thank you very much. The question is, well, if there is correlation with dexamethasone, well, there is an open question indeed, because we did not find any correlation between hormones and hyperglycemia. And we noticed that the patients are admitted and without hormones, they have elevation of blood sugar, they have hyperglycemia. And I think she needs more thorough diagnostics, and also she needs a test for diabetes associated with COVID. So whether she could just develop it. Maybe we are going to have this disease, diabetes associated with COVID, or COVID associated diabetes. So talking about cytotoxic action of COVID on all organs and pancreas as well. Well, personalized medicine plays the key role here, like my colleague previously mentioned, because the progression is very individual and we need to analyze each patient separately. Yes, we need just a set of measures of rehabilitation which are offered, but 6 months after, so the first rehabilitation, if the doctor has such a patient, he must create personalized rehabilitation and to understand what's happening with the patient. Well, as for prognosis of pancreatic cirrhosis, I think that's too sad. Maybe it will be much better. Thank you, Svetlana. We will believe in the best, hope for the best. That's difficult to just understand the reasons of hyperglycemia, because any inflammation is accompanied by hyperglycemia, and the same is true about steroids, which may cause thyroid diabetes. Probably these are the mutually enhancing factors, and there are articles which say that beta cells may be injured in case of COVID, which could give us grounds to speak about COVID, the COVID-associated diabetes. Still, there are different viruses which may cause diabetes, and that's not new for us. Thank you for your reply. And the next question to you: what are the peculiarities of COVID progression with the hyperglycemia, de novo, uncontrolled? What are the peculiarities of progression? Well, we don't see any peculiarities. They have the patients were moderate severe. We had very few severe, 2.3%, and out of them who died, well, the main sampling was almost 300 people. From hyperglycemic patients, nobody died in that group, and say that there is correlation here. Well, we cannot say that. Probably they just received very nice treatment. They were treated well, and they were thoroughly diagnosed, and there was a correction at all stages. And we don't have this data yet that hyperglycemia de novo may increase severity of the disease. It may impact the quality of life in post-COVID period. I think probably that is the main conclusion from our study. Thank you very much. One more question: are there any differences in diabetes which was previously diagnosed or de novo during COVID? So maybe it's not question 2, but you may have some data. Those who have diabetes, it's easier because they are just getting the standard treatment, and the doctors are aware. They know that they need to measure more the glycemic levels, insulin levels, and control their insulin intake, what they're taking. And the patients are well trained. They understand what they are doing. And it's not so bad in here. As for the patients who had hyperglycemia all of a sudden, they are a big surprise to doctors and also the patient herself, and they have COVID, and the doctor tells them, and you have elevated blood sugar, and then he starts to worry that he will develop diabetes, and the doctor is just trying to figure out what should he treat, COVID or diabetes. Should he cancel the hormones? What are the dosages? There are lots of questions. And we need to also train the doctors so that they understand what to do in the situation if the patient has hyperglycemia diagnosed and what to do in this case with the patient. Or for now, we just have the first ideas. We don't have long-term results. And we have only acute patients. And we treat them only at the hospital. And for the future, we are planning to have catamnestic follow-up of this patient, but it's just only a plan. Thank you, Svetlana. And from my side, as a endocrinologist, because I see those patients after discharge, well, diabetes is not proved after they stop with the glucocorticoids because they continue to take them in pills, but we see that glycemic indicators are being improved. So what will happen after 1 or 2 years? These high diabetic risks, well, probably that's true, but not all of the patients have the diabetes, their glucose level, when they go back to norm. And then I think the next question is to Dmitry. So Dmitry, what should we do for patients with the level of transaminase, high level of transaminases, despite taking the hepatoprotectors for more than 1 month? I would just select the diagnostic tactic and also additional diagnostic tests. Also, we should review what tests were done. Of course, markers to viral hepatitis were tested, and non-invasive diagnostics also should be performed. And we could do elastometry to clear the situation with the fibrosis, and then the age, whether he's taken certain drugs. The statins have such minimal biochemical effect, so the liver transaminases elevations, and the patients in pandemic times, well, they're taking some medication, and they take some herbs, and also maybe this is not the damaging factor of this phytotherapy, of this herbal treatment, and also maybe there is some interaction between different medications, and that's the effect of some drugs on elevation of liver transaminase. We are not going to discuss the hepatoprotectors, and also let us not discuss that over 1 month he's taking hepatoprotectors. We should be careful here, and maybe that was due to COVID. In such patients, we have up to 3-4 months. We follow them up, and they have even 2, 3, 5-fold elevation of liver transaminases. So does it going up or down? So we don't have enough data in the question, but you need to deal with that patient. And also, I would also mention that the clinical records, this hepatitis, or this is hepatopathia, Thank you very much, Dmitry, for such a complete answer. That would be strange to avoid IGOR. So IGOR, is there any data? So 1 minute and a half is left. Is there any data about COPD in patients with atrial fibrillation who take amiodarone? Thank you for the question. At present, we have not studied yet this disease. So we started more COPD patients, and there are specific defects, and the compliance is quite low. And as for treatment of these patients, for example, they have chronic heart failure and angina pectoris, so they have exacerbations when they take beta blockers. A small share of patients were taken verapamil, and I think based on the data available, that's difficult for me to say. And the last question is very practical. Probably somebody has this experience. So I would like to thank the lecturers. Please tell us how long the person can stay after COVID-19, moderate left lobe pneumonia to the right, gymoritis and tachycardia 135, shortness of breath, saturation decreases after walking to 93, 94, so 23 days after the onset. Well, he may just be on the sick leave as much as he can, so we don't have any limitations, so the patient should be treated, then he will be fine. We need to identify the reason of tachycardia. Maybe he has shortness of breath because of tachycardia, not because of lung pathology. And why the saturation is going down? Yes, he's still sick. We continue diagnostics. After he's treated, we'll discharge him. I would like to thank all of the colleagues who participate in our symposium. I'll be happy to see you in person next year in St. Petersburg. I hope that it will happen in person, not online. I would like to thank all of the colleagues who joined us, who spent these 3 days on our wonderful Congress of Internal Diseases. And goodbye. Thank you. Goodbye. Thank you, dear colleagues.